In general, there are a number of factors that we consider when making formulary decisions. First is certainly the rarity of the condition, and in rare conditions like ovarian cancer, where the cost is going to be relatively minimal and compared to other conditions, that might influence us to not to manage that category. But certainly we look at other factors. We look at the opportunity for misuse, abuse, overuse of a therapy. In cancer in general, there's typically not overuse, although there may be some misuse because providers are using things out of the appropriate sequence, line of therapy, or we're using the therapy too long after the patient's progressed because there are no alternatives available. We certainly look at cost effectiveness. If there are multiple drugs that have a similar mechanism of action and have similar outcomes, we're going to look at what the relative cost difference is for those and choose the one that's most cost effective. Having said that, again, in rare conditions, the relative cost may be very small, may be large, but the overall cost may be small. Again, that will influence our decision about whether or not we want to actively manage that category. One challenge for health plans is when drugs are similarly priced, what do we look at after that? Well, typically we look at efficacy and safety and then price. If we have therapies that are comparably priced, efficacy is probably the most important factor. Again, the challenge though, especially with the PARP inhibitors, is that all three PARP inhibitors were approved based on preliminary data, given accelerated approval based on overall response or on progression-free survival. There's a significant challenge, even more so in this space, because of the preliminary data and the challenges in looking at indirect comparisons. Complicating that even further is that the population studied were not comparable. Some studies were looking at BRCA mutation positive and others loss of heterozygosity. Some are looking at first line, second line, third line. And so the ability to make indirect comparisons is very challenging. And while the prices may be the same, the indications may be different. Frankly, as a health plan, until proven otherwise, we believe there's likely to be a class effect, and we may decide that we're going to manage these drugs after they failed their initial platinum-based therapy and allow access to any therapy and choose the ones that are most cost-effective. While health plans may simply choose to allow a PARP inhibitor in any line of therapy after a platinum-based therapy, they also may look at the breadth of the indication for a single agent and say this agent has the most indications, second line, third line, BRCA mutation positive, BRCA mutation negative, LOH positive and negative. The drug that has the greatest number of indications has the greater likelihood of being covered, but that depends on the physician as well. We may say we'll allow coverage for any indication, and if the physician wants to use something beyond the FDA label or beyond the study, if they believe that that's the most effective treatment for that patient, we may allow that. But again, having more indications gives you a greater likelihood of being covered than having narrower indications. An interesting question now that we have new therapies available, including Avastin and PARP inhibitors, is what to do about maintenance therapy. Interestingly, with the combination of platinum-based therapy with a taxane, we haven't done maintenance therapy because of the toxicities associated. So typically you would get 6 cycles and then stop, wait until the patient develops symptoms and retreat in a platinum-sensitive patient. But now that we have alternate therapies available that have fewer toxicities, the question is, what do you do about maintenance? I think the reality is that the data show that in patients who have platinum-sensitive disease, who have recurrence of their disease, that you can treat with a platinum-based therapy along with Avastin. You stop the platinum-based therapy and continue the Avastin until the patient progresses. Likewise, there are studies that show that you can continue the PARP inhibitor, if you're using that as a second or third line therapy, until the patient progresses. And then the third instance is where you can treat a patient with platinum-based therapy and then go into maintenance with a PARP inhibitor. So as long as the evidence shows that there is an advantage to that progression, it will be a covered service.